Good evening. Today I'm going to speak on the outcome of intravitreal ranibizumab monotherapy in the treatment of APROP at tertiary healthcare system. Now, retinopathy of prematurity, as we all know, is a disorder of the retinal vessels affecting preterm infants. APROP is the most fulminant form of the ROP, which many times progress to direct retinal detachment, stage 4 or stage 5. Two landmark studies, that is cryo-ROP, ET-ROP, have given their stepping stones for establishing their treatment guidelines, demonstrated satisfactory outcomes of peripheral thermoablation by cryotherapy or laser. But these therapies have not given satisfactory outcomes in the cases of APROP or zone 1 ROPs, because those babies required a larger portions of the retina ablations, and hence in the near greater future they are having myopia, strabismus, amblyopia, and all sorts of poor visual outcomes. In recent times, however, intravitreal anti-VEGF agents have given promising results, especially in these babies having APROP or zone 1 ROPs, by having swift resolution of the plus disease, as well as good retinal vascular development, and requiring less retinal ablation, and giving good visual outcomes. However, though many studies have been there, like BEAT ROP, Rainbow Trials, CARE ROP on these anti-VEGF agents, but there still remains controversy on the efficacy of these agents as monotherapy, and also regarding their safety. However, in the cases of injection ranibizumab, since it has shorter half-lives, both intravitreal as well as systemic, it has been many times used in various studies for retreatment under recurrence cases. So in this study, I have tried to evaluate the outcome of intravitreal injection ranibizumab as monotherapy in the treatment of APROP. It was a prospective interventional study done in a tertiary healthcare system in West Bengal. ROP screening was done as per the national guidelines. Inclusion criteria were patients who diagnosed with APROP and treated initially with intravitreal ranibizumab. They were followed up at least 6 months without any retinal detachments. Patients who were excluded from my study were, of course, those led to follow-up of less than 6 months, or any kind of other form of injections, anti-VEGF outside, or other forms of therapy like laser or cryo before. Also, patients with any kind of systemic infections, fever, leukemia, or eye infections were also excluded from my study. This was the procedure done step by step. And after taking the proper consent, the babies were injected with anti-VEGF injections, and I have selected altogether 12 preterm infants with 22 eyes with APROP. They were re-examined on the day 1 after the injection injected, and also weekly and bi-weekly as necessitated for 6 months. For every follow-up, reappearances, recurrences as well as regressions were taken into account. In cases of the recurrences, second intravitreal injection was given. An argon green laser was given to those babies who had insufficient responses, either with the persistence of the plus disease, or even after second intravitreal injection, or incomplete vascularization of the retina, even after 45 weeks of the PMA. Now, coming to the result, out of the 22 eyes of APROP, 11 eyes were of zone 1 posterior, zone 2 posterior APROP, and rest 11 eyes were of zone 1 APROP. There are some flow charts for coming into my details into the results. APROP after the first injection, there was regression happened in the 45% cases, but recurrence happened in 55% cases almost. In the regressed part, only complete vascularization happened in only 18.2% cases, and the rest remained incompletely vascularized. In the recurrence after giving the second dose administration of the injection, 18.2% of the cases there was persistence of plus disease, and the rest remained incompletely vascularized even after 45 weeks PMA. So except in this complete vascularization group, I had to apply laser to the rest all of it. So it required almost 82% of the cases. Coming to individual zone 1 APROP and zone 2 posterior APROP outcomes, zone 1 APROP had higher recurrences rate, but in zone 1 APROP, all the kids had incomplete vascularization, in addition to some infants who had recurrences and they had persistence of the plus disease also. So 100% of the zone 1 APROP ultimately required laser. In the cases of zone 2 posterior APROP, there was a percentage of 18.2% who got 36.4% who got complete vascularization. Only this percentage doesn't require laser, but the rest all required laser due to incomplete vascularization at the end of 45 weeks of PMA, in spite of my second injection. So, interesting facts I've already discussed about, but another interesting fact was also there, that lower birth weight was directly related. There was statistical significant relation with lower birth weight with the recurrence even after a second injection of my anti-VEGF. Coming to my discussion part, such huge recurrences were found in other articles also, and the possible response and the possible reason behind such huge recurrences was told that it was due to suboptimal response of the retina to a rapidly decreased VEGF level due to intravitreal ranibizumab. Also, in another article, it was even mentioned that there were possibilities for extreme preterm infants of having inherent problems of full retinal vascularization due to arrested advancing retinal vascular precursors. So this can be one of the reasons for why I have got the persistence of plus disease only in the cases of zone 1 APROP. Again, lower birth weight was found to have statistical significant correlation with recurrences and retreatment. These were my limitation, and hence I conclude that though injection ranibizumab is emerging as a safe option for the treatment of the infants with lower GI and birth weight, but remains controversial as monotherapy still now, it is of more help in zone 1 APROP to defer the laser and improve the visual outcome by ablating less peripheral retina. Thank you.
Just one question. Did you even include the babies? You are saying low birth weight babies. So babies, those who were in the ICUs, those who had under ventilators or with RDS and all, did you include those, or you have excluded those cases?
Madam, if they were extremely sick, if they had other kinds of those were would affect my studies, like severe sick babies, leukemic babies, low neutrophil counts.
No, that is okay. Those are okay. You have excluded those, but there are certain cases
normal yes, madam. Under screening criteria, those were not sick, extremely sick babies, I have taken into account.
Wonderful paper. I think this is one of the. I'm sure that most of the industry people will not accept your findings, but I agree with your paper completely.
Yes, sir, because I have also done work on laser, but it is giving very poor results to these APROP babies, because still many institutions are sticking to their laser therapies, because still many government institutions are having paucity of these ranibizumab injections. So we had to work on laser therapy for a long time, but giving very adverse outcomes to those babies. Then I have to go with good prognosis babies for anti-VEGFs, and I tried that whether I have to give a laser or not, but only deferring the laser only have helped me, not for
yeah,
for
we
the
agree
final.
with you. Giving the anti-VEGF is good enough in these babies, but one more thing is that even we give it for the patients, those who are even having certain, they are still in the ICU with the ventilator on also, where they cannot, means lasers cannot be given. Even those babies,
Yes,
they
madam,
are
yes,
indicated to be given.
Yes,
They work
of course,
more.
madam, because they are not in a position to take the
Yeah.
laser therapy. So my
But
only
still, I don't think so. This monotherapy will
yes,
help
madam,
still
I have
this.
also seen it is not working so much, because it is restricting the vasculature after a particular limit. Second injection has not helped it anyway.
Yeah.
So I have to stick to the first injection only.
So how many
And
days gap you are giving between the first and
that
second?
is 6 to 8 weeks. Whatever the recurrences was happening within 6 to 8 weeks. That's what I have seen in the West Bengal.
Okay.
Thank you, sir.
We had a laser monotherapy arm. They need to get it on. A laser monotherapy arm also along with this, and also we had the option of the second injection, and we had very similar findings with ranibizumab. And surprisingly, the advantage that is given with ranibizumab of lower refractive error and all. So the laser and that had similar rates of myopia as the one with ranibizumab, be it one injection, be it two injections. And the second injection invariably still required laser, and that was not the answer.
So that is the reason why we should have open research forums and free papers, and that is the reason why we should attend free paper sessions.
Rainbow is an absolutely biased trial, pharma sponsored. It's not the valid.
I do a lot of ROP, but the problem is that there's nobody ready to understand that this doesn't work. But there is so much of pressure from the industry.
It's a good drug, sir, for posterior zone 1
No,
and
there is
very
no doubt
severe
about
cases.
it.
It's a good drug for that acute phase.
No, we
but
are
it's
not.
not the monotherapy answer.
We are not fighting about the drug. We are talking in ROP. It is not something which ends everything. That is the only thing. We are not saying. You see, we cannot. There is some evidence which is already there that it is an anti-VEGF, so it will work like an anti-VEGF. There's no doubt about it. Nobody is doubting the efficacy. Problem is that when you go into the market in practice, I think only the number of people who are sitting here have listened to this, but most of the people in general think that, you give injection, you give
This
two,
is
what? You give
not
three.
an alternative to
Yeah,
laser. It is an
that's- I mean-
adjunct to laser.
The thing, you just have some time, that is the thing. Otherwise, it doesn't do much. Yeah.